So that covers the upper esophageal conditions. Let's talk about a few conditions that are associated with hematemesis or vomiting of blood. So I want you to, when you see vomiting blood on a test, there's not too many things they're going to try to test you on for step one, especially. So I want you to subdivide it between painless and painful hematemesis. If you see painless hematemesis, I want you to think bleeding esophageal varices. Okay. That's it. It really, there's maybe some other conditions that you could possibly consider, but for now, if you see painless hematemesis on step one, especially in somebody who has alcohol use disorder, I would highly consider esophageal varices as your one of your strongest answer choices. Now, painful has a few other options. You can get something called Mallory-Weiss Syndrome. You can get Boerhaave Syndrome, or you can get a ruptured peptic ulcer. So we already talked about bleeding esophageal varices earlier in the anatomy section, but I'm just going to go over it as a condition now. So that's the pathogenesis is dilated lower esophageal veins, and it's related to portal hypertension. And these dilated veins, they may rupture and cause really bad bleeding. So again, if this gets big, this can get big. And so we've seen this picture before. If you have portal hypertension, that portal hypertension can push fluid up into your systemic circulation. And because your systemic circulation isn't equipped to handle these kinds of pressures, you can get upper GI bleeding right there. So this will present, it can be asymptomatic bleeding. You could have painless hematemesis, which we just talked about. You could have melena, which is like coffee ground stool, and that's due to digested blood in your bloodstream. You could also get hematechesia, which is bright red blood, and that's usually due to undigested blood in your bloodstream. So if you have a esophageal varix that bursts open and starts flowing very, very quickly down your GI tract, it might not have time to digest, so it might look like bright red blood. And you treat this by surgical banding. And there's several medications you can give, more step two relevant than step one, but still good to know. You can give propranolol, that's usually prophylactically, but in the immediate setting, you can give octreotide. You usually give antibiotic prophylaxis. There's a few other things you should do in this spot. You should give them a PPI. You should type and cross them. You should put in 2 large bore IVs. You should give them blood if they need it. So there's a whole algorithm toward upper GI bleeding that I'm going to cover in the rectum section actually. But that's just something to keep in mind. And again, here's the picture we saw earlier with a bleeding varix. So for painful hematemesis, let's talk about these three steps in real quick. So we have Mallory-Weiss syndrome, and the pathogenesis of Mallory-Weiss is that you have a mucosal tear due to retching or vomiting. And so what does that look like? We've already seen our 4 layers of the GI tract right here: mucosa, submucosa, muscular layer, and serosa. And what's going to happen in Mallory-Weiss is that you're going to have a mucosal tear just in this layer right here. And it's a longitudinal tear. So if you imagine it's coming in and out of the screen, okay? And so this usually bleeds from the left gastric artery. I've seen that tested once or twice before. And so I'm going to go over the 2 arteries you really need to know in this area that bleed a lot. And so the left gastric artery can bleed, and there's the left gastric. That can bleed in Mallory-Weiss. We'll talk about peptic ulcers as well. It can bleed if you have a gastric ulcer, so that can all cause bleeding. And then just while we're here, I just wanted to let you know that the gastroduodenal artery can bleed profusely if you have a ruptured posterior duodenal ulcer. So if you imagine an ulcer right in this area, that can bleed and cause really, really bad bleeding. The risk factors for Mallory-Weiss, because it's a tear due to prolonged retching or vomiting, it kind of makes sense that the risk factors are going to be people who use alcohol excessively, especially binge drinkers, as well as people who have bulimia nervosa. And the presentation, as we discussed, it's a painful hematemesis. And this can increase your risk of Boerhaave syndrome. So it's a good time to talk about Boerhaave syndrome now. So Boerhaave syndrome is a transmural tear of the esophagus, which means it goes through all 4 layers. Okay, so this was Mallory-Weiss syndrome. In Boerhaave syndrome, instead of just affecting the mucosal layer, we're going through all 4 layers. And this could be very dangerous because this can rupture your esophagus. Another thing you might see is that air from our esophagus can infiltrate into the mediastinum and the associated tissues, the subcutaneous tissues. And so because there's a tear and now there's a pathway between our lumen and our subcutaneous tissues, air can actually flow right through that. And in pneumonic, I like to remember to differentiate Mallory-Weiss and Boerhaave syndrome is that Boerhaave can bore through the entire wall. And so here's some pictures of bores. These things right here, they can dig through. They can make huge tunnels. These are boring drills here. That's how I remember Boerhaave syndrome. And again, this is going to present with painful hematemesis after violent retching. As you can see, it's a very similar presentation as Mallory-Weiss. So you kind of have to work both of them up at the same time. You have to assume it's Boerhaave's, or you have to treat every Mallory-Weiss like it's Boerhaave syndrome just to be safe. But in Boerhaave, in addition to the painful hematemesis, you might actually, on a test question especially, they might mention this, this Rice Krispie feeling, this crepitus on the neck or the chest wall. And that's because air has escaped from the esophageal lumen into the subcutaneous tissues, and you could feel that air underneath the skin. You might also hear this phrase called Hammond's crunch. That's a crunching sound on the cardiac auscultation, and that's because air has entered the mediastinum. And so on how do you diagnose this? I've seen this, if they're going to give you Boerhaave's, they usually give you an x-ray or they talk about that crepitus. So you know it's not Mallory-Weiss. They're not going to try to trick you in that regard. So on a chest x-ray, you're going to see something called pneumomediastinum, which is air in the mediastinum for the reasons we've already talked about. And right here, you can see that air has already entered the mediastinum and it goes all the way up. So now to diagnose this is definitely not a step 1. This is more of a step 2 concept, but I'm just going to let you know anyways. You can give them a gastrographin or water-soluble contrast esophagram. That helps you see what's actually going on. The one thing they like to test here is they want to make sure that you don't give people barium in this spot because it can precipitate mediastinitis and kill the patient. And so I just remember the mnemonic. I think of it, I avoid barium unless I want to barium. So just as an idea. And then treatment, you have to surgically correct Boerhaave syndrome because the esophagus is actually ruptured. It's a surgical emergency. And the last one, I'm just going to touch on this because I talk about peptic ulcer disease in the stomach section, but I just want to let you know that the ruptured peptic ulcers can cause bleeding. Here's my chart from the stomach section that you can see. And we've actually already talked about this when we just talked about Mallory-Weiss syndrome. With bleeding ulcers, you can get really bad bleeds and signs of shock, or you can have subacute or very mild bleed. So you can have the whole spectrum of an asymptomatic bleed to somebody presenting to the ER in shock. And so gastric ulcers, they're going to be at the lesser curvature through the left gastric artery. So I already showed you this left gastric artery, the same artery that's affected in Mallory-Weiss syndrome. You can get an ulcer right here that starts bleeding off of that artery. And then posterior duodenal, we talked about the GDA, and that can cause bleeding right there. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.